Okay, we're live. We made it. We got the audio working. We've got microphones not well put away because they weren't working, but hopefully people can hear us. Guys, welcome to Cozy Talks. Raise your mugs, whatever you got in your glasses. Cheers. And folks, as you jump on board, that's a really cool mug.
I love it.
It's so cool. We were in Sarasota just not too long ago, and that is just like a mecca for Ferraris and Porsches and whoo.
I wish I could say I actually owned one, but I just own a mug. You know.
Well, that's what I said to my husband with the car key. I was like, you have a keychain.
That's right. So it just makes me feel good to drink out of it.
Very cool. All right, we got some people popping on board. We got Jill from St. Petersburg. Ashley, girl, you made it. Girl, you drinking your sweet tea tonight? You can hear us. Good. Thank you, Ashley. We've got Anthony with his Ultra Blue Monster. Pauline is on board. We've got Herb from Connecticut here. Right, AK. Glenda can hear us. Guys, thank you so much for letting us know that you can hear us. As you know, I am notorious for messing up my microphones and all that kind of good stuff. Guys, don't be shy. I love to hear from my audience. Let me know who you are, where you're from, and more importantly, what's in your coffee mug this evening. What are you drinking? Or if it's something more interesting than coffee, want to know about that too. Any newcomers on board? Let's see. So Dr. Tedeschi, if you look at the right hand of your screen, you're going to be able to hopefully see the comments coming in right now.
Yep. We've got a good paisan that just joined us here.
Oh, we got Johnny V in the Cozy Talks house from Poughkeepsie, New York. All right, let's see what else we got in here. Guys, we're going to give you guys about a minute or two to jump on board. If you can, tag people on board. This is going to be a really great talk tonight. I have never been able to talk about targeted muscle reinnervation until I found Dr. Tedeschi here, and I'm pointing in the wrong direction. There you go. Anyways, so happy to have him on board this evening. So guys, tag a friend. A lot of good information here. You'll be able to ask all of your questions about TMR. We've got Molly from Ohio. We got Sandy here. Whoop! Gainesville, another Floridian. All right. Jim says, does it count if I'm using a wine glass tonight? Red wine in St. Louis? Absolutely. Absolutely. And because I can't say, what's that?
I like what Jim's doing.
Yeah, I know, right? I would have my own, but then I wouldn't be able to say targeted muscle reinnervation over and over again.
Exactly.
So Glenda's got a strawberry margarita. Y'all got some really nice drinks going on here. Jordan from Utah. Susan, you made it. You're starting PT soon. Excellent. Susan, so excited that you are here. Harsh, your ears must have been burning because I was talking about you today, and we need to have a conversation later on. Robin is here. Oh, Robin. All right, we got a great crew on board, guys. We are going to go ahead and get started. We got Bonnie and Matthew. I love saying Maggie. We got Ireland in. Ireland is tuning in tonight. So what time is it over there in Ireland, Maggie? Go ahead and type that in the comments section for us.
Wow, she's in Ireland.
She's in Ireland, yes.
That's
she knew that this talk was happening, so she decided to jump in.
That's great. We were in Ireland actually a few years ago. Beautiful. Beautiful country.
Beautiful country. So guys, for those of you joining me for the first time, welcome. My name is Cozy Belloso. I'm a physical therapist, amputee specialist here in Tampa, Florida. I've been a PT now for over 17 years, and my passion is working with the limb loss community. Sitting in the hot seat tonight is Dr. Leonard Tedeschi, orthopedic surgeon, and I'm going to let him introduce himself.
Hi, everyone. You can call me Len. I'm an orthopedic surgeon, and I am a hand and upper extremity specialist, but I specialize in nerve surgery. And I am really excited about our talk tonight, TMR, which is the latest and greatest surgery for amputees. And I'm really excited about it. I learned about it a few years ago, and we'll get into that a little bit, and I'll tell you how I came across it and what are the benefits of it. But I'm really excited to be here and meet you guys. I've talked with Cozy on a few occasions, and she loves you guys, and she is passionate about you guys. She's passionate, period, and I'm sure you guys know that about her, but I think it's going to be wonderful, and I'm really excited to talk to you tonight.
All right, guys, we got a couple more of our regulars on board. We got Benny, Diana, and Jeffrey. Maggie, I apologize. You were in England, and it's 1:30 in the morning. My goodness.
Wow.
So you might need the coffee tonight, Maggie.
Yeah, right.
And we've got Barbara. Oh, wonderful. Good evening. She says, good evening, Cozy and Doctor, and she's from Connecticut.
Nice.
So, guys, like everything I talk about on the show, it's going to be a very brief description. I literally have here, I haven't taken this many notes since grad school. I have over 10 pages of notes that I took on TMR as I was doing my home. I know I'm a big nerd. As
You might know more than me.
No, no. As I was doing my homework for the show, and there's so much information that I'm not going to be able to include this evening, that we're going to continue doing more shows later on. Right. So this is just to kind of whet your appetite and just to let you know what it is. This is something that you're going to start seeing and hearing about more, especially with regards to the prosthetic technology. And right. Guys, finally, we are talking upper extremity amputee tonight. I know that's something I don't get to cover very often on this show, so I'm showing my upper extremity amputees some love tonight. So let's talk, hang on. Speaking of my notes. All right. So let's talk, we're going to give you guys a little bit of background information, and Dr. Tedeschi is going to be jumping in and giving us his expertise on all of this. We're going to start off by talking a little bit about myoelectric prosthetic devices, because that's basically the whole reason that kind of TMR came about. Okay. Yeah. So we hear this terminology being used, but what does myoelectric prosthetic device actually mean? Okay, some people like to call it, I like to call it the mind control prosthesis, because that's kind of what it looks like and how it acts like. Science fiction at its best. So our muscles generate electrical signals. We just produce it naturally. We're like kind of little Duracell batteries. We produce these little signals, okay? These sensors are located inside the prosthesis, usually in the socket, okay? It picks up the electrical signals from the muscle and amplifies it. And that is what powers the hand, usually in these myoelectric devices. Right. In your traditional arm prosthetic devices, where usually it was like a hook device at the end, the amputee would have to power it by moving the muscles in their shoulder girdle. Very labor intensive, requires a lot of strength. And if the person did not have a very long limb, it was very, very difficult to use. So Dr. Tedeschi, is there anything you want to add to that before we move on?
Yeah, no, you're exactly right. The old prostheses were mechanical in nature, and they required some type of body movement to activate the device. They could be unstable, right? Especially if it was a short limb, like you said. They may not fit properly. You generally couldn't hold a lot of weight with it. There was not a lot you could do with it. And it required a lot of like contortion and mechanical movements of your body. Right. The nice thing about myoelectric prosthesis is exactly what you said. It picks up electrical activity. Mm-hmm. You know, when the nerve that is connected to the muscle fires, an electrical activity goes through the muscle as well, because your nerves are electrical wires. They, mm-hmm. you know, conduct electricity. That's what they do. Mm-hmm. And so electricity comes down from your brain, down the nerve, into the muscle. There's electricity flowing through the muscle, and this pad that's sitting on your muscle picks up the electrical activity mm-hmm. and then performs a function. But the nice thing about that is you don't have to move your body a certain way. It's not mechanically driven, and you can just think about a movement you want to make or a muscle you want to activate that is going to power the prosthesis.
And guys, this is what makes me excited about being in my profession nowadays. This is something that 20 years ago, when I first started out, this was only in science fiction movies. Right. And now we are seeing it in our clinics. Yeah. So let's talk a little bit about, I'm going to use for tonight's talk, for the sake of demonstration, shoulder disarticulation. So that's the patient we're going to kind of talk about tonight. And Bob's here tonight. Hopefully he'll be behaving himself. All right, this is Bob. We just named him Bob. I don't know why, but just named him Bob.
Nice to meet you, Bob.
So with a shoulder disarticulation patient, okay, the entire arm is removed. That's it. No bone is left. So the humerus, this bone, the ball of the humerus is completely removed, okay? Right. What is left is basically the pectoralis major. Sorry for getting fresh on you, Bob. So the pectoralis major is that nice big fat muscle that sits right here on the chest. Now, here's where therein lies the rub. The muscle is perfectly healthy in most cases. It's a good muscle. There's nothing wrong with the muscle, except it's got nothing to really attach to and move. So it's just sitting there getting useless, atrophy, muscle wasting. So what they've done with this targeted muscle reinnervation is they basically reprogrammed the pectoralis major muscle. And this is a crazy oversimplified way of describing it. And I know Dr. Tedeschi is going to give a better explanation than I am. The muscle is innervated, it's two nerves, if I remember my anatomy correctly. It's innervated by Two nerves?
Yeah, two nerves.
Two nerves. I'm remembering my anatomy here. And the surgeon goes in and basically disconnects those two nerves. So now that pectoralis muscle is a free agent.
Correct.
The surgeon then takes all the nerves that are running here under the arm, the nerves that are left, the nerves that typically would control the elbow, the wrist, and the hand, and plugs those nerves back into the pectoralis major.
Right.
What's really, really, really cool is because the pec major muscle is so big, they can create different sections in that muscle for all those different nerves. So taking advantage of this nice big muscle. Your turn.
So let's just back up a little bit.
Yes.
And that was actually very true what you said. But let's give a little bit of a better understanding of the myoelectric prosthesis and why TMR is necessary and how it can drive the myoelectric prosthesis, because that'll help what you said make better sense.
Yes.
Okay? So TMR, or targeted muscle reinnervation, is exactly that. You're taking a nerve and you're reinnervating it. You're moving it, that it was performing one function, and you're going to make it now perform another function, but it's targeted. You know exactly where you're plugging it in. That's what targeted means. Okay? You're going to take this nerve, it, straightens your fingers, right? Like your radial nerve. Straightens your fingers, extends your wrist, and straightens your elbow. That's the function of the radial nerve. And you're going to take that nerve and you're going to plug it into a special nerve in your chest. And that muscle belly now is going to be innervated by the radial nerve instead of the lateral pectoral nerve, right?
Right.
And now when your brain wants to extend your elbow, it's going to fire that nerve. And because it's plugged into that part of your pectoralis major, that muscle is now going to fire. The myoelectric prosthesis is going to pick up that signal, and that pad is going to be connected to the part of the prosthesis that extends your elbow. Does that make sense?
Yep.
Okay, right? So when you remove your limb, you have all these free nerves sticking out there, and you can close up shop, and you can probably program a myoelectric prosthesis, which is what they used to do in the past, to pick up signals from your pectoralis muscle using the nerves that are there. But then you'd have to think about firing that particular part of your pectoralis major muscle, and sometimes you don't get it right. But if you plug in your elbow nerve, to make it very simple, if you plug in the elbow nerve into that part of your muscle, it doesn't even mean that you're trying to flex your pectoralis muscle. You're trying to extend your elbow. So if you think, I'm going to extend my elbow, all of a sudden your pec fires, and the myoelectric prosthesis picks up that signal and extends the elbow in the prosthesis.
It's right? More intuitive. It just, and that seems to be what I see in the literature. It's more intuitive in how the nerves are surgically placed.
Yep.
It's going to make more sense to the person. And even
it's your natural function, right? It's your natural function.
It's the natural function.
So the other important word that I think everyone needs to understand is pattern recognition. Okay, because sometimes it's really hard to get all the nerves in the right places. This happens also in the lower extremity, and I know that they really don't have myoelectric prosthesis yet in the lower extremity, although that's coming. Pattern recognition is extremely important, especially in lower amputations, right? Because you can plug in nerves in a variety of different muscles, and then you can put a bunch of different pads on a variety of different muscles. And depending on how you fire those muscles, you can program the prosthesis that when it sees this particular pattern of muscle firing, it closes the hand, it opens the hand, it turns the wrist, whatever it is that you want it to do, and you can program it a lot of different ways. And that's what's great. There's modularity now in the system. So you can program things, you can fix things, you can tighten things, you can make them squeeze harder, squeeze less hard. I mean, it's unbelievable what you can do nowadays.
It is. It is. And I know we have the majority of my viewers are lower extremity amputees, but like I say, you're an amputee. It's good to learn about all the different things going on because eventually it's going to trickle down to you in terms of technology. We've got, let's see. Oh, Jeffrey jumped on board. Nicole, I'm so glad you could join us this evening. Christy says, Boney Bob, is that what we're calling? Right. Lynette's on board. We got a couple of PTs here on board. So this is wonderful. Pat, I am so glad that you are listening this evening. We've got Linda and Joe. Oh, Jody, I'm so glad you made it this week. No worries. You can watch the replay. So guys, now that you've got kind of an overview of what it looks like for the upper extremity and targeted muscle, and this has been going on, sorry, I'm backtracking here a little bit, about 20 years now that we've been doing
about
TMR?
that, yeah, about that. And it started off, with upper extremity amputations where they were just trying to plug the muscles in to get a better sense of the, pattern recognition for the myoelectric prosthesis. Mm-hmm. What they found is that it significantly helped phantom pain, prevention of neuromas, and, just generalized pain in the residual limb, right? Residual limb pain.
Yep.
And then they started doing it in the lower extremity, right? Because they saw like, hey, these guys aren't getting phantom pain. These guys feel great. They probably went back, and I don't know the whole history, but they probably went back and did it in some patients, who had their amputation, who knows, 6 months, a year prior. And these people probably had pain, phantom pain, and they saw, oh my gosh, it helped their phantom pain. So then they started doing it in the lower extremity, and the results have been fantastic.
And we're gonna backtrack just a little bit on that because again, this is a particular topic that I've wanted to talk a little bit more about. So let's kind of segue into the lower extremity, guys. What exactly happens during a lower extremity amputation? Okay, the basics of it is surgeon cuts through skin, surgeon cuts through muscle and soft tissue, cuts away all of the dead and necrotic tissue. That is the goal of the amputation, to cut away as much of the dead tissue and preserve as much of the healthy tissue as possible. The bone is cut and then the nerves are cut. And then basically a soft tissue envelope is created, hopefully stitch the patient back up again, and off we go. Now, again, oversimplification. The sad thing is unfortunately, this has been the same, very similar technique for amputation since the Civil War days and probably even before then. Just thankfully nowadays we have much better anesthesia and pain medication for folks undergoing this surgery. But in terms of the nerves, we're going to focus a little bit on the nerves because I know in my own practice, one of the biggest things I see with folks is not only the phantom pain, but problem with neuromas. And whenever I have a patient come in that's having a pain and I've ruled out residual limb pain and I've ruled out a couple of other things and it's finally getting to neuroma on the inside, I'm just going, ugh, because they are a bear to deal with.
Well, actually, they're pretty simple. It's pretty simple. I really like, they're the easy ones, right? If a neuroma is what's really bothering you, I mean, even if you just go in and cut the neuroma out, they get significantly better. The problem is it can grow back, right? So yes. Neuromas are easy to deal with. Once you plug them in somewhere and you give them somewhere to grow, something to do, you get rid of that. It's really the residual limb pain that's the problem because, I tend to think it's related to the nerves, and sometimes TMR works for that, and sometimes it doesn't. And we can get into a whole lot of that. In fact, I think it's really important. Can I just give a little bit of physiology and anatomy?
Yes.
So nerves are electrical wires, like I said before, right? Mm-hmm. They basically come from your brain, and it's not a straight shot. There's a series of connections and a series of levels and interconnections. Mm-hmm. But essentially, nerves come from your brain. They go down through your spinal cord. They come out the spinal cord, and then they go down into your limbs, whether it's the arm or the leg. And when they first come out of the spine, they form a plexus, whether it's the lumbar plexus or the sacral plexus in your lower extremity or the brachial plexus in your upper extremity. And then they split and they form several major large peripheral nerves, right, that go down the limb, and they bring both motor and sensory fibers down the limb. Motor fibers bring electrical activity from the brain down to the muscle. Mm-hmm. Sensory fibers bring electrical activity from the skin and from the joints, and so there's proprioception, and there's hot and cold sensation and sensitivity and vibration that they perceive, and they bring it back up to the brain, and then your brain's like, oh my gosh, I just burned my finger, right? That's what your nerves do. They conduct electricity. They're electrical wires. When an amputation needs to be done, the old way to perform that is you pull on the nerve, you cut it, and you let it retract back into the muscle. Mm-hmm. The nice thing about your peripheral nerves is that they regrow. They sprout nerve fibers, free nerve endings, because they're trying to connect into what's called an end organ. End organs can be Pacinian corpuscles in your skin, free nerve endings in your skin. They can be proprioceptive organs in the joints, and they can be muscle, right? So your muscle the nerve can connect to your muscle. That's an end organ. It has something to do. The nerve now has something to do. It has an activity. It's not like a downed electrical wire in the street that's just zapping all over the place. Does that make sense? Right?
Absolutely. Yeah.
I love that analogy because that's exactly what happens. When you touch a person's neuroma on their leg, they freak out, right? Mm-hmm. They jump back, they freak out, it hurts, they get this sting and electrical shock. It's unpleasant. That's because it's a free nerve ending. It's just sitting there. It's like a down wire in the middle of the street. Yep. You need to take that nerve, and what we've learned is you take that nerve, you got to plug it in somewhere so it has an end organ to grow into. Now, the nerves that are important are the sensory nerves. The sensory nerves, remember, bring information back up to your brain. Yep. So they are the ones that if there's a neuroma on a sensory nerve, you're going to know it because you're going to feel it. It's the sensory nerve. Mm-hmm. The motor nerves also form neuromas, but the electrical activity is going the wrong way. So even if you have a neuroma on a motor nerve, you're not going to know it. You're not going to feel it. It doesn't matter. So the point is to take the sensory nerves, cut out the neuroma, cut back to healthy nerves so that it can sprout nerve endings. Mm-hmm. But now you're going to take that nerve and you're going to plug it in somewhere. And there's a variety of different ways to do that. One of the things they used to do in the past, a couple things they used to do in the past to fix neuromas is they used to drill a hole in the bone. They take that nerve ending, plug it into the bone, and let it grow in there. People still had problems. They used to take the nerve ending and they would bury it in a muscle. Mm-hmm. People would still have problems. Why would they still have problems with the muscle? Because the muscle, if you just plug it into a muscle that already has a nerve plugged into it, there are no free end organs, mm-hmm. right? You need a free end organ. If you take that muscle and you clip the nerve that is controlling that muscle, which is a motor nerve, right? Because people are always like, but you're clipping a muscle, you're clipping a nerve, you're going to get a neuroma on that nerve. Yes, you will, but it's a motor nerve, so you won't feel it. You clip the motor nerve, you plug the sensory nerve into the end that is going into the muscle, mm-hmm. and you perform a repair there. And now that free sensory nerve grows into the muscle nerve and into the muscle. And you close the circuit. Anybody who's an electrician will understand what that means.
Yes.
You close the circuit and their pain should go away. And they should not form another neuroma.
That's beautifully explained. Guys, if that makes sense. Oops, I'm echoing. I don't know why. Guys, if that makes sense, give us a thumbs up in the comment section. Say, makes sense, downed wire. Let us know what you think. That is a really amazing analogy. And it's like what we said earlier, guys, when they're doing the TMR on the pectoralis and the shoulders articulation, surgeon has to cut the nerves to the pectoralis major so that it then becomes available for rewiring. Rewiring, essentially.
Right. Reinnervation.
Yes, reinnervation. Right. All right, it all makes perfect sense. Okay, good. So this being said, first question. Who would be a candidate?
Okay, so who would be a candidate for what? what are we talking about? There's a variety of different things, right?
Mhm.
We have phantom pain, we have neuromas, we have, you know, uh, uh, myoelectric prosthesis. So, first of all, any patient that is getting an amputation should have TMR in my book. And at the hospital where I work, I mean, I have had countless conversations with people about this because if you don't do it, you run the risk of patients having problems with phantom pain. You run the risk of them not being able to use a myoelectric prosthesis later on in life. And the reason why it's important is because if you don't do it right away, your brain is plastic. There's neuroplasticity. It actually changes. Anybody who's familiar with the homunculus on the brain, that picture they draw with the face and the hand and the body and the legs on a strip of the brain, the gray matter.
Yep.
That gray matter, it actually changes over time because that limb is no longer there. Your brain actually changes and those nerves start to do other things. Getting it to change back may be impossible. So we don't have enough studies on that yet, but we do know that after a certain time, neuroplasticity occurs and you get changes in the brain. And that's why people continue to have pain in their limb, sometimes despite doing the TMR, because they're too far gone. Okay? So every, what I call fresh amputation, for the lack of a better term, every fresh amputation should have TMR. And if you do it within the first month or two, you should be fine. After that, you start to develop some neuroplasticity. However, there's a lot of studies coming out where they've done it in patients who have had their amputation years prior and they're doing fine. Okay. Now, the longer you go, the less likely it is to get better. I mean, I had a patient who had an above the knee amputation and he was 16 years out, had a lot of phantom pain at night on occasion. It wasn't every single day. And I said, look, I don't know if this is going to work. It may work, it may not work. And we talked about, the plastic changes in the brain. And I did it. And, 3, 4, 5 months went by and he still didn't see any benefit from it. So, not everybody's going to get better, but if you're going to have an amputation, it's planned, or someone else who's going to have an amputation, they should have TMR. Prevents neuromas, prevents phantom pain, prevents residual limb pain. You're less likely to need long-term narcotics or spinal cord implants and stimulators. I mean, a lot of these patients, they just live with pain. They're taking medical marijuana and all kinds of other stuff, and this can really help prevent all of that. So if it's a trauma or vascular disease, I mean, right now I'd say do it in your diabetics too. I don't think the jury's out on that yet. Excuse me. But I would say anybody who's getting an amputation, just do it. You're not going to lose out.
Right.
And then on top of that, they have the ability or possibility of using a myoelectric prosthesis.
I know that the osteointegration procedures that they're doing, they're kind of preparing for the future use of a myoelectric prosthesis.
Right.
We actually have an occupational therapist here on board listening in. She works a lot with her amputees, and we actually have a former OR nurse who used to do a lot of amputations, so she's listening in as well. Yeah. My question is, and guys, go ahead and start posting your questions in here. I already see one from Johnny. My question is for folks who have revisions for whatever reason, will the TMR be beneficial to them even if they are years out from their rehabilitation?
Absolutely can be. And I see, Johnny asked, did the Erdl procedure incorporate TMR? It doesn't matter how you do the amputation. Right. The TMR is completely separate. In fact, the way we do it in my hospital is someone will do the amputation, right? So maybe one of my partners or somebody will do the amputation because they happen to be on call or they were taking care of the patient. They tried to salvage the limb. It didn't work, or the vascular team will perform an amputation in a trauma patient, and then they'll call me and I'll go in. Doesn't matter how they did the amputation, how they closed it, what they did. I'll go in and I can always do the TMR. I have to do it through a separate incision,
Right.
maybe 2 incisions, depending on what's there and what level it is. But I can always do it, no matter how the amputation was performed.
No, and it's like you said, if you have to choose basically between having the nerve stretched out, cut, and letting it retract and ball up into a potential nasty neuroma, or
Right.
taking your chances and plugging it in.
I mean, actually, you're with the studies that are coming out, you're really not taking chances. It's the better procedure.
Yeah.
And I tell all my patients, let me do this operation. If this was my leg, I would have this operation, because you're taking a risk. Now, look, nobody wants to have extra surgery if they don't need it.
Right.
But if you don't have it done and you develop the plastic changes in your brain, there might be no going back.
Now, I lost my train of thought for just a moment. What should people look for? Because the whole reason it's taken me almost 2 years to have this talk on the show is because there's really not a whole lot of people in my area who do TMR.
Right.
How can people look for a surgeon who does TMR, and what should they be looking for?
Well, first of all, if you Google TMR, it's going to pop up. I mean, there's tons of videos on it. There's a lot of people starting to do it now. There is a really good website, and I don't like to advocate for any particular pharmaceutical company or anything like that, but there's a nerve stimulator that I use, and the reason why I like this company is because their nerve stimulator is better than, in my opinion, is better than the other nerve stimulator on the market. But they've also incorporated in their website TMR, and they have information about what it is. They have videos, they have research articles, and the company is called Checkpoint Surgical. I don't get any, kickbacks or, nothing from them.
Got it.
But I do like their nerve stimulator, and there are other ones on the market that I've used that work fine. But I do like their website. It has a lot of information on TMR.
Okay.
So you can search that way. And it is hard. It is hard. I mean, if you just go and you ask your orthopedic surgeon, mm-hmm. Can you do TMR on me? He's going to be like, what? What's TMR? Right? Because a lot of people don't know about this yet. It is gaining a lot of popularity, especially in the people coming out of training now, right? They're hearing mm-hmm. about it, they're learning about it, mm-hmm. and a lot of people coming out now know about it. And there are certainly specialized centers across the country that are doing this procedure. I am actually going to put together a website. It's in construction right now, and I'm going to have information about myself and about TMR and how you can contact me. But if you have questions, I'm happy to talk to you about it and take you through it and discuss it with you. But there is not one single website that you can go to and say, I need a TMR doctor. You know what I mean?
Yep. People are still okay. Oh, we got some questions rolling in here. Jim asks, how receptive are the insurance companies?
So I do get, they don't understand it either. Okay. Now, the insurance companies are paying for some of the, the part of the procedure. Mm-hmm. And that's fine. I do it and they pay me. They don't pay me for the whole thing, but that's okay. It's still worth it to do it for the patient because, I don't know how you can look at yourself in the mirror if you're not doing something to help somebody, despite whether or not you're getting paid for it, right? Like I couldn't look at myself and I couldn't in the mirror when I wake up in the morning. I couldn't sleep at night if I didn't do it. But yes, if you code for it properly, you can get some payment for it. Absolutely.
Okay. And then Maggie says, our gal from England, she says her amputation was due to trauma, but it was an elective for years after the injury. She had TMR recently at the time of amputation. She's a right BK. Our occupational therapist, Andrea, says our local surgeon is also a hand plastics who does TMR surgery like you, nerve focused. She's in Gainesville. Right. She's a Gator. Yep. And then Ashley has a great question. Is TMR exclusive to orthopods or could a vascular surgeon do this?
Yeah, vascular surgeons are not trained in nerve surgery, but people like plastics and mainly guys like me who are hand trained and do nerve surgery, those are the ones that are doing it, right? So it's plastic surgeons and nerve surgeons, orthopedic, hand and upper extremity. Those are the ones that are really doing nerve surgery. The other guys, none of the other orthopedic surgeons do nerve surgery.
Got it. Molly says, what a good man. Amen to that, Molly. Amen to that. All right, guys, here comes a little fun part. So interesting story. First of all, we're going to be doing our live giveaway for tonight. And while we're doing that.
May I ask one question?
Yes.
I just want to know, Maggie had her operation done 4 years after the injury. Did she feel like it helped? Right? 4 years is now, you're starting to think, is there, what happened with her brain?
Did it work or did it not work? Yeah. And guys, any of you out there who've also, if you've had TMR, I know there's a couple of my patients who have had recent revisions with TMR, and I know a few of you have piped up and said that you had TMR. So if you don't mind, if you feel comfortable putting it in the section here, if you had TMR and what was your outcome? Did you have a positive outcome from it? Let's see. Jonathan asks, hey, Kosi, I'm receiving my first leg 1.5 years after I lost my right leg below the knee. My question is, will I face any challenges getting my leg so late after my amputation? So, Jonathan, a lot of my patients don't receive their leg right away. Some of them have a lot of problems with their wound care management. Some of them have other comorbidities, other illnesses that prevent them from getting better and well enough to use a prosthesis. Many of my patients come in to see me 3 years after they've had their amputation, simply because they never had the opportunity to work with a PT to properly learn to use their prosthesis. So while I completely agree with Dr. Tedeschi about neuroplasticity and certain things kind of being set in stone, for me as a PT, I love how the brain can relearn certain functions. And he used a lot of keywords that you guys have heard me use a lot on this show: proprioception, okay? And working the proprioception. So Jonathan, you definitely need to work with a specialized physical therapist who can teach you how to use the leg and how to get into it. Your challenges are going to be unique to you. And I know that sounds like a little cliche answer, but every single amputee who's come into my clinic is completely different, whether they're fresh out or whether they are years out. But yes, it is definitely possible to learn how to use your prosthesis and to be successful with it, but you need your team with you. Let's see, we've got Johnny here.
May I answer a question for Bonnie?
Yes,
Bonnie said, if it's up a little higher. It says, would this work if you're going to become an AK after being a BK?
Yes. Thank you.
Yeah, I think it will. I mean, I would definitely do it, because, again, the part of the brain that controls the part of your leg below the knee is a little bit different than the part of your brain that controls above the knee. So if I was going to convert you to an AK, I would absolutely do TMR. Okay. Yes. So there was another question that I was going to answer here too.
Johnny has one. And guys, if I missed your question, please repost it again.
Yes, Johnny actually has a great question here. I would absolutely do TMR on you. If it's a real amputation, you should get some relief. I mean, I'm sorry. If it's a real neuroma, I apologize. If it's a real neuroma, you should get relief. I had a guy who actually went to my church who got cut with a knife, and he had a neuroma, I don't know, over 10 years. And it was a real neuroma, right? Neuroma is you have an exposed nerve, right? You get a nerve cut. I'm sorry. You get a nerve cut on your arm. You touch it right where it was cut, and it's like, ooh, it's a zap. That's basically a neuroma, okay? Yeah. So I went in there. I found the nerve. I cut out the neuroma. I traced it all the way up the arm. And then I opened it up, in the forearm here, and I plugged it into a motor nerve in a dispensable muscle, right? It has to be dispensable so that you don't lose any function. The worst thing to do is to take a motor nerve and then they lose function, right? So it has to be dispensable, and he got better. So I think you should get better if you get that neuroma taken care of. It's worth a shot.
Out of curiosity, which muscle do you remember?
I think it was the superficialis, the flexor deformans superficialis.
FS, yep, okay.
Yeah, so you want to take that and not the profundus, because the profundus goes all the way out to the tips of the fingers, right?
Right. This is cool.
Yeah.
Let's see, Maggie says.
Somebody had TMR done and it did well.
So Maggie just said yes. Maggie's our gal from England. She said yes, it has helped. She was 4 years out.
Okay.
And she doesn't have much phantom pain. So that's very
Right.
interesting. Jody asks, this is a great question, Jody. How do you know if you've had TMR?
Okay. Well, I'll tell you, up until 2 years ago, nobody was doing it, right? Very few people were doing it. Some guys in Ohio and Boston and uh, Minnesota were doing it. But besides that, not a whole lot of people were doing it. So if you had your amputation 3, 4, 5 years ago, you probably didn't have it done. But I always tell people that I'm going to do it. And you should have been told, because it's part of your consent form, right? You know, like I'm going to do X, Y, and Z, and you got to give me permission to do it. If you don't want me to play around with your nerves, you should say no, right? I mean, that's how consent works.
Before you sign on that dotted line.
Right.
And yeah. And Jody, oftentimes, you know, my patients come in, they never know what kind of foot they have, because once the prosthetist puts the foot shell on it, we have to really dig in there to see what kind of a foot they have. And B, they don't know how their amputation was done. And the more I practice, the more I'm trying to find out the surgical techniques that were used. And that's part of the information we couldn't do tonight that I want to do on another show. You know, did the surgeon do a myodesis? Did they do tenodesis? You know, how did they connect those muscles? Where did they connect those muscles? And don't even get me started on this new Amy procedure that we're seeing. That's a whole nother cool.
See, I think a lot of those procedures were done because people had pain and they didn't know what to do about it, right?
So we started rewiring and reconnecting and seeing
They're just moving stuff around. And the truth is, you don't need to move anything around. You need to deal with the nerves, right?
Yeah. So folks, what I'm trying to say is you have the right to ask for your OR report.
Yeah.
You know, you have, in my own case, in my own personal history, many of you know I went through breast cancer and I had to go through several surgeries. And after each surgery, because, you know, you're signing on that consent form, and then a lot of the stuff flies out of your mind as you're dealing with surgery. So that's very understandable. But I would ask my surgeons, can I please have my OR form? Because I want to see what you did, because it's going to affect how I do my own physical therapy moving forward. And you can ask for this, guys. It's part of your medical record. Jody, the fact that you don't have any phantom pain, Jody, can you tell me when you had your amputation done? Let's see. Joe says, Joe, I'm so sorry. If there's any specific question that I can help you with, Joe, please put it in that comment section to see if we can help you out. Let's see. Maggie says mainly just phantom sensations, but not pain. And guys,
that's a win.
That's a big win. And I explain this a lot on the show, but I always like to repeat it for folks who are listening for the first time. There is a difference between phantom pain, phantom sensation, and residual limb pain. And I'll just give a brief description. Residual limb pain is exactly that. It's pain that's in the actual limb that is still there. It could be coming from the bone. It could be coming from the muscle. It could be coming from the nerves, but it's from what is actually still there. Phantom sensation is exactly how that name implies. You can sense the foot or the leg that was cut off. Okay, and many of you, pretty much all of my patients say, yes, I can still feel my foot. I can feel a little itching. I feel the side of my leg brushing up. And that is different from phantom pain. Phantom pain is when you can feel the foot and then there's a lot of pain associated with it. And there's so many different kinds: burning, crushing pain, tearing pain, spike pain. But it's good to understand the difference between those three, because how you treat it is very different.
Yeah. I wouldn't do TMR on someone who just had phantom sensation if they've never had TMR done, right? They don't have pain. They're not waking up in the middle of the night. They're sleeping well. They wear their prosthesis without a problem. You know, there's no problem with prosthetic fit, or and they don't have any neuromas. They just feel their foot or their hand or whatever every once in a while. I'm just not sure. I would not recommend surgery to that person.
Right. And for the most part, at least what I hear, again, from what I hear from my patients, the phantom sensation, it's a little bit of a nuisance, but not interfering with their function the way phantom pain or residual limb pain can get in the way of daily activities. Let's see, we got a lot of comments flying in here. I love it. See, Susan says, I had an RPNI with a BK revision. Whole thing failed. Susan's been going through a rough patch right now. I had an AK.
So RPNI did not work. That's interesting. RPNI is exactly what. So what you're doing with that is you're not plugging the nerve into another nerve.
Mhm.
You're taking a piece of local muscle, and I do this too. Like if I have a nerve and I have nowhere to plug it in, I do RPNI. You take a piece of muscle that's close to that nerve, you denervate it, right? You have to cut it enough so that there's still blood supply to it, but no nerve supply to it.
Mhm.
So now there are end organs free, right?
Yeah.
Theoretically. And then you take the nerve and you wrap the muscle, the end of the nerve, you wrap that muscle and close it up tight. So now when the nerve sprouts, that muscle doesn't have any nerve supply to it. It can actually plug into the end organ there. That's the theory of how it works.
Got it. And she also just had stages 1 and 2 of the osseointegration.
Oh, really? Okay,
Yeah,
great.
she had the AK with TMR and OI stages 1 and 2. So she's a month out from her stage. I believe. Oh golly, Susan, darling, remind me where again you're being treated. That just left my brain right now. I'm so sorry. Let's see. Beth asks, left below the knee, little hamstring and glute, walking with loft strands. Any suggestions? Beth, can you clarify just a little bit more? Meaning, are you looking for glute and hamstring strengthening? I know that for all of my amputees, whether you're a Symes, below the knee, above the knee, anything above that, any strengthening of the glutes and whatever's left of the hamstrings is incredibly important. I strengthen from head to toe, but definitely the power muscles and the glutes and the pelvic hip muscles are a huge part.
Yeah, I'm struggling to understand what she means by little hamstring and glute, right? I don't
know. Yeah. If you can clarify that for me, Beth, I'd appreciate it. Let's see. Woo, these comments. Joe had a guillotine amputations. Wow. Let's see.
Yeah, I mean, people should, if you can at all prevent performing a guillotine amputation, you should, because a guillotine amputation, you're basically just cutting straight down and taking everything off. And when you do that, you're basically making the patient have to go back for another operation where they need to shorten the leg more. And that's what you want to avoid, right? The shorter the limb, the higher energy output required to function the prosthetic.
Yep. And that's something you guys have heard me talk about. And also with the guillotine, they have to go up higher because there's no soft tissue to wrap around, is from what my understanding.
Yeah, there's no skin to close there, right? So in order to get the skin closed, you got to cut back more bone, more muscle, so that now you have that skin that you can wrap over and close.
Yep. So Jody had hers 3 years ago. Jody's the mystery one that she doesn't know if she had TMR or not, and she had it done by Plastics. So
Plastics performed her amputation.
Mm-hmm.
I mean, they'll usually tell you like you're gonna have an amputation with TMR.
Okay.
Right?
So
because an amputation is one thing, TMR is a completely different operation.
Yeah.
Right.
Let's see. Jim asked, any foot or ankle prosthetic use of TMR or manufacturers working to incorporate for lower limb loss? I've heard tickles about it on the grapevine, Jim. I cannot give you any accurate information, so I'm not going to answer that. Right? I can't answer definitively. All I can say is that it's happening a lot for the upper extremity prosthetics. So I know the research is starting to trickle down to lower extremity prosthetics. Dr. Dedesi, have you heard of anything specific for the prosthetic?
Yeah, so they are working on lower extremity myoelectric prosthesis. Is that the question?
Yes.
Yeah.
And when
so they're working on it.
If there is a
company,
particular manufacturer.
Yeah, I don't know off the top of my head who's doing it, but I know they're working on it. Usually your prosthetic people should know. And, the prosthetic people I use up here, like they have their finger on the pulse. They just know everybody and everyone. They actually are the ones that, got me more involved with TMR. And they told me that, yes, they are working on it. People are working on it. Manufacturers are working on it, but it's not nowhere close to what they're doing in the upper extremity.
Yeah, but we're gonna start seeing it, and I'm excited. I'm really excited about it coming down the pike.
But
so
the truth is, though, sorry to interrupt.
No, not at all.
The truth is, in the lower extremity, TMR isn't quite as important. It may be a little bit more important if you have an AK, but if you have a BK, except for maybe like some ankle motion, you don't really need motion of your toes. There's no, there's no, toe motion that's going to help you function a little bit better. But a little bit of, ankle motion, dorsiflexion, plantar flexion, maybe a little eversion and pronation and supination. But besides that, it's not a whole lot of lower extremity, functions that you're going to miss if you don't have one. Would you agree with that or no?
Yes, what I see it in terms of, and yes, and we're starting to see that, with some of the certain prosthetic feet with the hydraulic units, for example, the microprocessor hydraulic units that allow for that dorsiflexion and plantar flexion, and how much of a difference it makes in some of the patients' lives in terms of quality of their movement and efficiency. The other thing that I'm kind of curious about, and again, I don't know as much as you do about this, the sensory side of TMR. So from my rudimentary understanding, if the person who's had TMR on the pectoralis, if they are touched in the top part of the pectoralis and it's innervated, would it be the median nerve?
Well, there's the median nerve, radial nerve. It depends on what part. Yeah.
What part that they would feel their hand, almost like an induced phantom sensation. And I don't know if I'm saying this right or not.
Well, what they're doing is they have leads, electrical wires that are connected to the surface of the prosthesis, and those electrical wires are then plugged in through the skin and attached to certain nerves in your arm, right? Maybe even into the brachial plexus, that when you stroke the prosthesis, that it picks up that electrical activity and the electrical activity will fire onto the nerve, and then that nerve will pick up the electrical activity and send it to your brain, and you'll feel it. Okay. I don't know how well it works right now.
Right.
But I do have some concerns about it. And the same thing with osseointegration. You're taking an outside foreign body, for the lack of a better word. You're plugging it through the skin. In osseointegration, you're taking a piece of metal and you're sticking it through the skin into the bone. So now you have direct entrance of a foreign body through the skin into the inside of your body.
Through the stoma,
which is a high risk of infection. And I've heard doctors who do osseointegration basically talk about how people who have it are generally going to live with some level of infection around the bone. Right? So now you have these wires sticking into your chest, and I'm thinking, is that a good idea? Right?
It's a foreign body. It's like having a catheter. It's something that is a potential there.
Correct. It's great. The technologies, I think they're going to get it right, but you have to be able to live with having wires through your skin.
So it'll be interesting. It's definitely something I'm going to be following very closely to see what comes down the pike from this. Let's see. We've got Angela as a newcomer. Hello, recently became an AK last month. Welcome, Angela. So guys, tonight, you guys who have been with me for a little while, I love to do free giveaways. I have 4 kids, so whenever I hear free giveaway, you see me at the computer just waiting to see what it is all about. And we have a very unique giveaway tonight. So how I met Dr. Tedeschi is kind of one of those, like, it was just kind of meant to happen. There is a beautiful website. It's called COL 1972. And as you can see, Dr. Tedeschi is wearing one of their shirts, Culture of Life 1972. Beautiful clothing website. I love clothing. I love fashion. I'm actually wearing one of their really nice blouses right now.
I thought that looked familiar.
Yeah, you like it? It looks familiar.
Is that 1972 in the corner of the shoulder?
Great. There it is.
Oh, I see it now. I see it. Yeah. Oh, that's great.
So long story short, I was calling the company because there was a particular size on a particular dress that I wanted. And the owner of the company, Carla Tedeschi, picked up the phone. And as we were chatting, very friendly, we realized we had a couple of acquaintances in common. And for what, I don't even know how it happened, my show came up in the conversation. And she said, wait, you deal with the amputees? And I go, yeah, that's my specialty. She goes, my husband's an orthopedic surgeon and he works with amputees all the time. And I said, well, I've been looking for a surgeon to put in the hot seat. So that's how, poor guy, you got roped into this.
Actually, this is a lot of fun. I might have to start my own show here.
There you go. So guys, Culture of Life, for my ladies out there, it's a beautiful website, beautiful pieces of clothing. Gentlemen, if you're looking for something for your sweetheart, you want to check out this website. And actually, I'm going to go ahead and post the link to the website there so that you can check it out. And Carla, Dr. Tedeschi's wife, was so sweet, and she donated a $50 gift card to this website. So we had earlier a sign-up raffle, and I went ahead and I pulled the name out of the raffle before we started the show. And the winner of this raffle is Megan Hill. So Megan, congratulations. Congratulations. You are going to love this website. I was already eyeing it before we started the show tonight. I've already got a couple pieces picked out again myself. So Megan, I'll be contacting you so we can send you your $50 gift card. So guys, I think we've gotten most of the questions. Guys, as always, if I missed your question, it was on accident and I apologize. Feel free to please send me your questions to my Facebook Messenger. I answer questions 7 days of the week. There you go. Megan's on board. Oh, pretty good. Yay. Megan, you're gonna have a good time with this gift card. I do want to take this time to thank Dr. Tedeschi for coming on board this evening. It is an honor to have you. Thank you.
My pleasure. My pleasure. You have a great crowd here. They're very energetic, ask a lot of questions. I mean, they seem like really awesome people. So
they are.
Nice. Coach C is something special. Don't let her go.
Thank you. And guys, as always, if you have any further questions for Dr. Tedeschi, you can either send them to me and I will make sure that he gets them. And as he puts up his new website, I will be certain to put that information up on my Facebook page so that you guys can keep tabs on him. So guys, as always, thank you so much for letting us be a part of your lives this evening. We will see you next week. Same bat time, same bat channel. Bye guys. God bless.